My name is Kenneth Christopher. I'm an assistant professor in medicine at Harvard Medical School. We're going to talk about acute kidney injury and renal replacement therapy. I have no conflict of interest. We're going to first talk about acute renal failure or acute kidney injury in the ICU. We'll also talk about when to initiate renal replacement therapy in acute kidney injury. We'll talk about whether dose matters or whether modality matters. The incidence of acute kidney injury in the ICU is approximately 6%. A high proportion of these patients with acute kidney injury need renal replacement therapy, and in-hospital mortality is still quite high at around 50%. In a large worldwide prospective observational study, 54 intensive care units, the most common contributing factor to acute kidney injury was septic shock. 30% of patients had pre-admission renal dysfunction, and overall hospital mortality in those who developed acute kidney injury was 60%. Risk factors for hospital mortality included the need for vasopressors, mechanical ventilation, septic shock, cardiogenic shock, and hepatorenal syndrome. In 2004, the RIFLE criteria was created by the Acute Dialysis Quality Initiative Workgroup, and this is composed of 3 levels of renal dysfunction, which is risk of renal dysfunction, injury to the kidney, and also failure of kidney function, and 2 levels of outcome, loss of kidney function and end-stage kidney disease. In an almost linear relationship between RIFLE severity and mortality exists. This is data from a retrospective single-center trial of 20,000 patients, and hospital mortality for the groups of the RIFLE class was 4% for normal patients, 15% for risk patients, 29% for injury patients, 41% for failure patients. All RIFLE criteria were significant predictor factors for hospital mortality with an increase in odds ratios with increase in severity of RIFLE criteria. A reliable marker of early kidney injury in serum or urine has not been clinically validated or widely put into practice. Candidates that have been under investigation include NGAL, NAG, cystatin C, interleukin-18, and also kidney injury molecule 1. These biomarkers currently have not become standard of care in terms of evaluating patients with acute kidney injury. Regarding sepsis acute kidney injury, dynamic changes of serum creatinine in the first 24 hours of ICU admission has major prognostic significance in sepsis. Acute kidney injury in patients with SIRS or sepsis can be predicted at the onset of sepsis on the basis of older age, elevated serum creatinine, increased central venous pressure, and also liver failure. Data supports a more nephrotoxic or cytokine-mediated mechanism of injury rather than what's considered an ischemic mode of injury. Optimization of renal perfusion may be a factor for prevention and treatment of acute kidney injury in septic patients. There are no pharmacologic or extracorporeal treatments that are currently in use to treat sepsis-related acute kidney injury. And unfortunately, mortality of septic acute kidney injury is far higher than non-septic acute kidney injury. With regard to contrast-induced acute kidney injury, this is associated with an increased 30-day and overall mortality. There's higher mortality risk in patients who develop contrast-induced acute kidney injury after intravenous contrast administration as compared to intra-arterial. In terms of prevention, it's important to use low osmolar contrast media. Intravenous fluids appear to be better than oral hydration prior to procedure in some studies. With regard to N-acetylcysteine, there is an unclear benefit, but a low risk profile and a low cost. Sodium bicarbonate has an unclear benefit over saline. And with regards to the use of hemodialysis after contrast administration, there appears to be insufficient evidence. With regard to acute decompensated heart failure, chronic kidney disease or acute kidney injury are shown to be associated with adverse outcomes during treatment of acute decompensated heart failure. There are mixed results of trials comparing ultrafiltration with diuretics in acute decompensated heart failure. And with regard to volume overload treatment, there doesn't appear to be an advantage of ultrafiltration over diuretic therapy. And a negative large randomized controlled trial on nasiratide in decompensated heart failure showed that this particular therapy was not helpful. Looking at acute kidney injury after cardiac surgery, perioperative use of aprotein increases the risk for acute kidney injury and adverse outcomes after cardiac surgery. With regard to prophylaxis in cardiac surgery, phenoldiprem looks as if it is not helpful. There is a negative trial reported in 2014. And acetylcysteine prophylaxis trials have not shown consistent benefit. And mannitol in small studies suggest no utility. With regard to hepatorenal syndrome, volume unresponsive, refractory prerenal azotemia in patients with chronic liver disease, characterized by systemic and splanchnic vasodilation, but profound renal vasoconstriction without parenchymal kidney injury, is the definition of hepatorenal syndrome. Hepatorenal syndrome is divided into two types, a type 1 or a type 2. Type 1 being severe, and without liver transplantation, prognosis is so poor that therapy is considered futile. With regards to prevention or treatment, there are small studies that suggest some efficacy of a combination of albumin and terlipressin therapy in improving renal function in hepatorenal syndrome, but do not address clinical outcomes, and other small studies that suggest that norepinephrine may offer similar potential benefit to terlipressin. With regard to rhabdomyolysis, blood myoglobin by dipstick is present, and classically no red blood cells are present on microscopic examination, and rhabdomyolysis can be detected by the presence of red pigmented casts on urinalysis. Rhabdomyolysis benefits from aggressive volume replacement. Traumatic rhabdomyolysis, fluid resuscitation is beneficial before the crushed extremity is released. Urine alkalization may increase the solubility of heme proteins within the tubule. Alkalization may decrease the redox cycling of myoglobin, thereby reducing the generation of reactive oxygen species. And the use of mannitol appears to be no better than expansion with normal saline. In rhabdomyolysis, there appears to be no benefit for dopamine, furosemide, or N-acetylcysteine. With regard to atherosclerotic disease, atherosclerotic disease occurs with a delayed development of acute kidney injury after an angiographic procedure in terms of arterial specifically, or a AAA repair accompanied by symptoms of systemic atherosclerosis. Muscle, GI, CNS, skin can all be involved. White blood cells appear in the urine, and white blood cell casts may be present. In atherosclerotic disease, there is a high likelihood of dialysis requirement if the kidneys are involved. And if the kidneys are involved with atherosclerotic disease, there is a high likelihood of dialysis dependence. What happens is the cholesterol crystals become embedded in the distal arterioles, an inflammatory reaction follows, and the tissue distal to the now obstructed arteriole becomes ischemic and necrotic. With regard to abdominal compartment syndrome, oliguric acute renal failure occurs after abdominal trauma in patients who have required aggressive volume resuscitation. Intra-abdominal hypertension is defined as intra-abdominal pressure of greater than 12 millimeters of mercury on 3 measurements obtained 4 to 6 hours apart. And abdominal compartment syndrome is defined as the presence of an intra-abdominal pressure of greater than 20 millimeters of mercury that's associated with a single or multiple organ system failure that was not previously present. The treatment of abdominal compartment syndrome is abdominal decompression. Let's talk about acute interstitial nephritis. This is a hypersensitivity reaction most commonly to penicillin, sulfa-based drugs, or NSAIDs, but can occur with any medication. Inflammatory cells are present in the renal interstitium, and this leads to tubular damage. Retrospective studies of patients do not appear to support the routine administration of corticosteroid therapy in the management of acute interstitial nephritis. However, it is possible that immune modulation with corticosteroids may be helpful in some cases. Mycophenolate mofetil may be used as a therapeutic option for steroid-resistant or steroid-intolerant acute interstitial nephritis. With regard to renal recovery, this is an important question that patients and families will ask. There is no way to predict when and if a patient will recover. In general, a longer period of renal replacement, greater than 3 weeks, has less likelihood of recovery. Long-term recovery in patients who require renal replacement for greater than 6 weeks is possible, though unusual. What has to happen is the repopulation of damaged renal tubules, and this occurs by proliferation of tubular epithelial cells and resident renal-specific stem cells. There is a role for paracrine factors from the bone marrow-derived mesenchymal stem cells. Growth factors also have an important role in the repair process in animal models of renal injury, such as IGF or hepatic growth factor and erythropoietin. Oftentimes what happens during renal recovery is the patient is exposed to a second renal injury. And what this does is it disrupts the repopulation of damaged renal tubules and can result in significant chronic kidney disease. Let's talk about when we initiate renal replacement therapy. So our primary therapeutic goals in patients with acute kidney injury are to optimize hemodynamic and volume status, to decrease the likelihood of future renal injury, to correct the metabolic abnormalities, remove the uremic toxins, and also to potentially permit adequate nutrition. In terms of the absolute indications for renal replacement therapy, absolute indications include volume overload that is not responsive to diuretics, severe hyperkalemia that is unresponsive to medical intervention, metabolic acidosis that is, again, unresponsive to medical intervention, or overt uremic signs and symptoms. In terms of renal replacement therapy, in general, we have 2 modes that we use in the intensive care unit. We have hemodialysis and continuous renal replacement therapy. Continuous renal replacement therapy can be broken up into slow, low-efficiency dialysis, continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, or the combination, which is continuous veno-venous hemodiafiltration, or peritoneal dialysis. With regard to hemodialysis, blood is pumped from the patient to the filter that has a large surface area for approximately 4 hours for every 48 hours. The purpose of hemodialysis is to remove solutes quickly, such as creatinine, BUN, potassium, and toxins, or to add solutes quickly, such as bicarb. In addition, hemodialysis can remove water at between 125 to 1 liter per hour. Hemodialysis works on the process of diffusion. Solutes are removed or added with diffusion down concentration gradients of the dialysate. There's a blood compartment, a filter, and a dialysate compartment. So the difference in terms of the gradient of, say, potassium of 6 and a dialysate set at 2 favors potassium removal, whereby a patient bicarb of 15 but a dialysate of 35 favors bicarb addition. In terms of ultrafiltration, that's water removal via negative pressure. And toxins and drugs can be removed if they are in the circulation and if they are not bound to protein and if they are small enough to fit through the pores of the membrane, which is any molecule that's smaller than albumin that's not bound to protein that is in circulation can be removed. With regard to continuous renal replacement therapy, blood is pumped from the patient to the filter that has a large surface area for 24 hours a day, approximately. The purpose of the continuous renal replacement is slow solute removal of things like creatinine, BUN, potassium, and toxins, or slow solute addition of bicarb. It also allows for slow water removal at between 0 to 150 or 250 mLs per hour. Continuous renal replacement therapy works via convection, where solutes are continuously removed via negative pressure and water is continuously removed via negative pressure. Replacement solution is given that has all of the things that you need in your serum that you have removed with convection, such as sodium, chloride, bicarb, potassium, etc. Toxin and drugs can be removed, again, if they're in circulation, if they are small, and if they're not bound to protein. So in terms of our primary therapeutic goals in continuous renal replacement therapy, we want to remove solutes via diffusion and convection. We want to add solutes via replacement fluid. We want to remove fluid via convection, and also to detoxify the patient of toxins or drug metabolites. The Acute Dialysis Quality Initiative Work Group found variations of up to twofold in the reported levels of urine output, blood urea nitrogen, and serum creatinine at the time of initiation of renal replacement therapy. There is uncertainty still as to when to begin renal replacement therapy, and complications of chronic renal failure may have much more severe consequences for critically ill patients who have acute kidney injury. Renal replacement therapy should start prior to complications of acute kidney injury. In terms of the timing of initiation of dialysis in ICU patients with acute kidney injury, large multi-center observational study of dialysis initiation from the Picard study looked at 600 patients with acute kidney injury in intensive care units, or 243 patients who had estimated GFR of greater than 30 on admission who required dialysis for acute kidney injury. This study examined the risk for death within 60 days from the diagnosis of acute kidney injury by the BUN at the start of dialysis in a low azotemia group and a high azotemia group. Following adjustment for age, liver failure, sepsis, thrombocytopenia, and serum creatinine, and also stratified by site, the relative risk for death associated with high BUN at intermittent hemodialysis initiation was 1.85, indicating that patients with higher BUN burdens at the time of initiation of dialysis had an increase in mortality. When we look at creatinine and critical illness, serum creatinine directly affect the assessment and classification of patients with acute kidney injury, also the time of initiation of continuous renal replacement therapy, and also the prognosis in critically ill patients. Small increases in creatinine are related to worse outcomes in heterogeneous hospitalized populations. Creatinine values depend on several factors, including age and gender, race, volume status, the amount of lean body mass, and the protein intake. Serum creatinine are proposed to be a surrogate indicator of nutritional status. Higher serum creatinine values, or the capacity to generate creatinine, may be related to better health status or better outcomes and survival in the ICU patients. Conversely, low creatinines of less than 0.6 milligram per deciliter have been shown to increase mortality in patients in the ICU. So in many ways, creatinine is a proxy for lean body mass, which is associated with nutrition as well as with severity of illness. In severe acute kidney injury, a higher serum creatinine is paradoxically associated with better patient survival. Interesting study of 134 patients looked at higher serum creatinine on initiation of continuous renal replacement therapy, was found to be associated with better survival, controlling for selected covariates, about a 40% improvement in survival. Adjustment of the model by several factors, including pre-admission chronic kidney disease, severity of disease, decreased or annulled the significance of the serum creatinine levels. Higher creatinine itself appears to be an indicator of better nutrition and muscle mass, but may also be related to severity of disease and pre-admission chronic kidney disease. With regard to modality, does modality matter? Does it matter how you deliver renal replacement therapy in the ICU? So what type of modalities do we have? We have intermittent hemodialysis, sustained low-efficiency dialysis, sustained low-efficiency hemofiltration, CVVH, or continuous veno-venous hemofiltration, the combination of CVVH-D, which is continuous veno-venous hemodialysis, and continuous veno-venous hemofiltration is called CVVH-DF. We have high-volume hemofiltration, peritoneal dialysis, etc. Current data do not provide objective criteria for selecting among these modalities in the majority of patients. In many cases, there are specific types of modalities that may help you manage patients, but it looks like the outcomes themselves do not depend on the type of modality that's given. In terms of the clinical practice worldwide, observational study of 54 ICUs. Of those requiring renal replacement therapy for acute kidney injury, 80% were placed on CRRT, 17% placed on intermittent hemodialysis. Half of those on CRRT were CVVH, and 34% were a combination between CVVH and dialysis. A study done in comparison of continuous and intermittent renal replacement therapy for acute renal failure on 191 patients, ICU patients with acute kidney injury requiring renal replacement therapy. 70 patients were randomized to continuous veno-venous hemodiafiltration and 55 patients randomized to intermittent hemodialysis. What was found is that the ICU mortality for the CVVH-DF was 34%, and the ICU mortality for the intermittent hemo was 38%. In terms of the hospital mortality, CVVH-DF was 47%, and the intermittent hemodialysis patients was 51%. So fairly close in terms of the outcomes for the different renal replacement therapy methods. Randomized control, multi-center, non-blinded study in 21 French ICUs compared continuous veno-venous hemofiltration versus intermittent hemodialysis for acute renal failure. 360 patients were randomized to hemodialysis versus continuous veno-venous hemofiltration, with 37 patients crossing over. There was no difference in hemodialysis versus continuous veno-venous hemofiltration in terms of outcome. And over the length of stay, there was significant increase in survival rates in the intermittent hemodialysis arm, while the survival rate was the same for the CRT arm, suggesting that it took some time for the practitioners to get used to and master intermittent hemodialysis in sick, multiple organ dysfunction syndrome patients. With regard to intermittent versus continuous renal replacement therapy for acute renal failure in adults, this is a RCT comparing CRRT with intermittent renal replacement therapy in adult patients with acute kidney injury. 15 studies were identified with 1,550 patients. CRRT did not differ from intermittent hemodialysis with respect to in-hospital mortality, ICU mortality, hemodynamic instability. Patients on continuous renal replacement therapy were likely to have higher mean arterial pressures, but also higher risk for clotting dialysis filters, probably associated with the increase in filter exposure time to blood. Let's talk about whether the dose of renal replacement matters. In terms of the renal replacement dose, a prospective trial of 160 patients enrolled in an alternating fashion, treated with daily hemodialysis and alternative day hemodialysis, found better uremic control, fewer hypotensive episodes, faster resolution of acute renal failure, and lower mortality amongst those with daily intermittent hemodialysis treatments versus alternate day treatment. Ronco showed benefit with higher doses of continuous renal replacement therapy, where randomly assigned 425 patients with acute renal failure either received ultrafiltration continuously at 3 doses, 20 ml per hour per kg, 35 or 45, and survival was significantly higher in the 35 ml per hour per kg group and the 45 milliliter per hour per kg group in comparison to the 20 ml per hour per kg group. The VA NIH Acute Renal Failure Trial Network study was designed to clarify the optimal dose of renal replacement therapy in critically ill patients. This is a multi-center prospective randomized parallel group trial of high intensity versus low intensity renal replacement therapy in critically ill patients with a primary study endpoint of 2-month all-cause mortality. And the trial was designed to allow for patients to receive both CVVH or CRRT and intermittent hemodialysis, depending on changes in hemodynamic stability over time. And the investigators in this trial found no difference in mortality in high versus low intensity renal replacement therapy. A study done at University of Alabama called the Standard versus High Dose CVVH-DF for ICU-related ICU renal failure defined acute renal failure or acute kidney injury as volume overload, oliguria, BUN greater than 80, potassium greater than 6.5, increase in creatinine greater than 2.5, or a sustained increase in creatinine greater than 1 over baseline, where 200 patients were randomized to high, 35 ml per kg per hour versus low, 20 ml per kg per hour dose of continuous renal replacement therapy, similar to the Ronco study. And the primary outcome was survival to ICU discharge or to day 30. And the investigators found that there was no difference in mortality in the high versus low intensity renal replacement therapy, signifying that dose may not actually matter in 2 separate studies. The renal replacement study investigators designed and implemented the intensity of continuous renal replacement therapy in critically ill patients trial. This was ICU patients with acute kidney injury, 1,500 patients who were randomized to high, 40 ml per kg per hour versus low, 25 ml per kg per hour dose of continuous renal replacement therapy. The 2 study groups were similar in terms of baseline characteristics and received study treatment for an average of 6.3 and 5.9 days, respectively. At 90 days after randomization, 322 deaths occurred in the high-intensity group and 332 deaths in the lower-intensity group, for a mortality of approximately 45% in each group. And in addition to no difference in mortality, there was also no difference in renal recovery. So when we look at high-volume hemofiltration and acute kidney injury, high-volume hemofiltration is defined as ultrafiltration of more than 35 ml per kg per hour. In a meta-analysis of 4 separate trials that included 470 participants, there appears to be insufficient evidence to exist for a therapeutic benefit for the use of this high-volume hemofiltration for septic acute kidney injury. In terms of the forest plot for the odds of 28-day mortality, the odds ratio is 0.82 with a confidence interval that crosses 1, indicating no significance. With regard to high-volume hemofiltration and sepsis, the IVOR study, a randomized controlled trial of 140 ICU patients, found no evidence that high-volume hemofiltration at 70 mL per kg per hour, when compared to 35 mL per kg per hour, leads to a reduction of 28-day mortality in septic acute kidney injury. So in summary, we talked about acute kidney injury in the ICU with an incidence of approximately 6%, with a high number of these patients requiring renal replacement therapy and a high in hospital mortality. When do we initiate renal replacement therapy in acute kidney injury? Earlier may be better. Does the actual modality matter? We find that continuous renal replacement therapy does not appear to be any better than intermittent hemodialysis for survival. And dose. Does dose matter? It looks as though, looking at the evidence, that less, in terms of a lower dose, provides the same outcome difference as a higher dose renal replacement therapy. Let's move on to the board questions. So board question 1, a 24-year-old male has his legs pinned under a pile of rubble following an earthquake. He's extracted after 12 hours, is found to have scant red urine, CPK of 46,000, and a serum creatinine of 1.9 milligrams per deciliter. Which one of the following treatments would have decreased the risk for acute kidney injury in this patient? A, intravenous crystalloid, initiated before extraction. B, mannitol. C, dopamine. D, furosemide. E, N-acetylcysteine. The answer is intravenous crystalloid, initiated before extraction. Urinary alkalization may increase the solubility of heme proteins within the tubule. The use of mannitol is no better than expansion with saline, and there's no benefit for dopamine, furosemide, or N-acetylcysteine in this particular setting. Board question number 2, 74-year-old male with diabetes, congestive heart failure, and creatinine of 2.1 is admitted with a non-STEMI and is scheduled for a coronary angiography. Which one of the following would be associated with the least reduction in the risk for contrast-induced nephropathy? A, 250 ml infusion of isotonic sodium bicarb over 1 hour before angiography, followed by 75 mL per hour for 6 hours post-angiography. B, a continuous infusion of isotonic sodium chloride at 75 ml per hour for 12 hours prior to angiography, continuing for 12 hours post-angiography. C, a 250 ml infusion of isotonic sodium chloride over 1 hour before angiography, followed by a continuous infusion of 75 ml per hour for 6 hours post-angiography. D, a continuous infusion of isotonic sodium bicarb at 75 ml per hour for 4 hours post-angiography. And E, a continuous infusion of isotonic sodium bicarb at 75 ml per hour for 6 hours prior to angiography, continuing for 6 hours post-angiography. The answer would be D, a continuous infusion of isotonic sodium bicarb at 75 ml per hour for 4 hours post-angiography, in terms of which of the following is associated with least reduction in the risk for contrast-induced nephropathy. With regard to prevention of contrast-induced nephropathy, we're looking for low osmolar contrast media. It appears to be higher than high osmolar in terms of outcomes. IV fluids may be better than oral hydration prior to the procedure. N-acetylcysteine shows unclear benefit. Bicarb shows unclear benefit over saline. And hemodialysis has shown insufficient evidence. It's important to prehydrate patients, whether it's with isotonic sodium bicarb, whether it's with sodium chloride, or whether it's with oral hydration. Board question number 3, which one renal replacement method has the highest probability of in-hospital survival? A, intermittent hemodialysis. B, CVVHDF, that's continuous veno-venous hemodiafiltration. C, sustained low-efficiency dialysis. D, continuous veno-venous hemofiltration. Or E, all are equal. So all of these options are equal. Survival does not depend on modality of renal replacement in acute kidney injury, with the exception of peritoneal dialysis, which has been shown to be inferior to the other techniques. In board question number 4, in CVVHDF, that's continuous veno-venous hemodiafiltration, which of the following is present? Convection. B, diffusion. C, dialysate. D, replacement solution. Or E, all of the above. And the answer is all of the above. CVVHDF is continuous venous hemodiafiltration. This is the combination between continuous hemofiltration, or convection, and continuous dialysis diffusion. Hemofiltration uses a replacement solution, while dialysis uses a dialysate. So the combination between a continuous dialysis and a continuous hemofiltration uses convection, diffusion, dialysate, and replacement solution. Board question number 5. 34-year-old man develops severe oliguric acute kidney injury after a thoracotomy, and he has no evidence of sepsis. His CVP is 12. Which is the best strategy for treatment? A, continuous venovenous hemofiltration with an effluent flow of 60 mLs per kg per hour. B, continuous venovenous hemodiafiltration with an effluent flow rate of 40 milliliters per kilogram per hour. C, continuous venovenous hemofiltration with an effluent flow rate of 20 mLs per kilogram per hour. Intravenous furosemide at 20 milligrams per hour, or intravenous normal saline at 75 cc's per hour. The answer is C, continuous venovenous hemofiltration with an effluent flow rate of 20 milliliters per kilogram per hour. The data that we reviewed does not support the use of high dose in continuous renal replacement therapy. A lower dose is more cost effective and just as efficacious as a higher dose. With regard to modality, there's no survival difference between CVVH and CVVHDF. Intravenous furosemide would not allow for solute clearance. Intravenous saline would likely not have any effect in this case.